Hello, everyone. I have Dr. Mallorie and Dr. Allea here today with me from Tonic and Phasic Physical Therapy Group. And we're here to talk about endometriosis, pelvic pain, and how physical therapy can be incorporated into your treatment plan for pelvic pain. So I'm going to start by asking Allea a question. Dr. Allea, what is physical therapy?
Great question. So physical therapy, well, we're pelvic floor physical therapists. So that means that we specialize really from the diaphragm down to the lower parts of the pelvis. We treat conditions like urinary urgency, urinary incontinence, prolapse, pelvic pain conditions like endometriosis, pudendal neuralgia. We also treat bowel dysfunction, sexual dysfunction as well. But I always like to do a pelvic floor 101 with people so they know exactly what I'm talking about when I talk about the pelvic floor. So if I am sitting here, right, this is what I look like. I have my two waist bones. The waist bones meet at the middle at the pubic symphysis. These two bones are your sit bones. And when you wiggle back and forth, this is what you should be sitting on. We have this socket right here, our hip socket. So where our legs come out of, we'll flip it to the back. We have our vertebra and then our sacrum and then our tailbone right here. And then all of the red are the pelvic floor muscles. So we have these superficial pelvic floor muscles right here that can be felt externally. This is right behind the vulva, that external tissue. And then we have our pelvic organs that sit inside the pelvic bowl. So we have our bladder that sits right behind the pubic symphysis, our uterus, and then our rectum behind, right here. And then we have all of the muscles internally right here. So we have these muscles that make up the levator ani. And so you can think of these like the Kegel muscles that contract and relax to store bowel and bladder. And then we have these muscles right here that are for more support and stability. So they help keep our pelvic organs in place and they help stabilize our pelvis from the inside.
That's a great description of the anatomy of the pelvis. But can you tell us more, Dr. Allea, about how physical therapy can help with pelvic pain?
Yeah, so
I'll go ahead and tell that one. So when it comes to pelvic pain, what we do is we approach it from more like this holistic lens. So we're not only physical therapists, like Allea was saying, but we're also herbalists, nutrition coaches, hormone coaches, and pain coaches. So with our approach, we say pelvic pain is here. And then we have little branches that come off of that. So one area is the structural system that we look at to see like what is going on, what's causing your pelvic symptoms, which could be, like she was saying, urinary urgency, urinary frequency. It can be pain with intercourse. It could be painful urination, painful bowel movements, but even lower abdominal pain that you're experiencing. That is all consisting of pelvic pain. So when we think of the structural system, we're going to think about everything she just explained with that pelvic model. What's going on with those hip bones? What's going on with the pelvic floor? What's going on with your breath or your rib cage? So we think very structurally, musculoskeletally. Then we look at hormonal components. How's your menstrual cycle? Is it short? Is it long? Is your luteal phase not sufficient enough? Are you having hormone imbalances? And so we educate through tracking your menstrual cycle, basal body temperature, maybe even giving some herbal supplements to kind of help you ease those symptoms. Then we look at your nervous system, and that's another branch of that. With that nervous system, it's what is your relationship to pain? How do you perceive pain? How long have you been experiencing pain? It could be what emotions are you feeling right now? Are they stored within the body? Because there are so many factors that can lead to body tension, not just structurally. It could be the way our nervous system is relaying that to our body. And then the last but not least, we think about systemically. And so this is where Dr. Behbehani comes involved, because we work so collaboratively with people and we're like, okay, if it's not her nervous system, it's not the hormonal system, maybe it's not structurally, it has to be something else, endometriosis or something in that nature. We like to refer, we want to look at labs, maybe have you ever taken a functional test? So we look at this big picture and we call it a pelvic blueprint. And we create that and we go through that as a plan to help you get out of pelvic pain.
That's a great way of putting it, as
Mhm.
part of a big plan. So when do you think women should seek physical therapy? Because like you said, I'm a surgeon, I operate on my patients for endometriosis, and then I always recommend that they see a physical therapist as part of their treatment plan. But when do you recommend patients should seek physical therapy for pelvic pain?
Yeah, that's a great question. So ideally, we want to see people, honestly, whenever you first start experiencing pain, that would be the ideal situation. However, that doesn't usually happen. So, if you can't see a pelvic floor physical therapist, we're usually then referred by doctors. And so people can come in for pre-surgery to prep for their surgery to have the best outcomes. And so sometimes that can be between 6 and 12 weeks long. And then post-op as well, we will see people for about 6 to 12 weeks. And this also is depending on the complexities of their condition. So if it's a more lower complex, we may see people just for a couple of visits. If that's moderate complexity, we may see people for 8 to 12. And then if it's a higher complex, we may see people for 16 weeks plus. Again, depends. So it's all dependent on the complexities and then also working with their physician on what's their right plan of care.
I agree. So I often send my patients to see physical therapy as we come up with our surgery plan. Sometimes we have surgery scheduled in a week or two and they don't have time to see a physical therapist. But other times there's a lag between when I see my patients and when they're able to get in for surgery. And so we utilize that time to establish care with a physical therapist so they can at least learn the infrastructure, the exercises that they need to go through. And then after surgery, oftentimes my patients ask me, when can I resume physical therapy?
Yeah.
So I think it all depends on the communication between me as a surgeon and my team, the physical therapist team. But I usually say wait at least 2 weeks. I see my patients at 2 weeks after surgery just to see how they're doing with the healing. And if everything looks like it's going well, then they can definitely resume physical therapy at 2 weeks. If they're still sore, they're still going through recovery, then we can wait a little longer. But at 6 weeks, almost everyone is ready to go back to physical therapy. And I don't know if you agree with this, but I think the sooner they go back to physical therapy, the less likely it is that their muscles will stay in that tonic position.
Yes.
So tell us what a session of tonic and phasic looks like.
Yeah, so I'm gonna go off of what you were just saying. So let's say someone just had surgery. We're gonna go based on that scenario. Typically we do see people a week out. Now we don't do internal during that time. We allow your body just to recover, and we really just don't go into that aspect of the care until about 6 weeks, or until the physician, if Dr. Behbehani was like, she's great to go, everything's nice and healed, then we do internal. But we will start externally. So the scar tissue, we'll work on abdominals, we'll work on breath work, even like letting go of tension up in the upper cervical region, doing some vagus nerve stuff to just kind of get you back into your body and present, maybe giving you tips. Like, let's say, for example, post-op, you're sneezing, you're like, I have so much pain. There's a lot of tips we can give you to have less pain when you're sneezing, coughing, maybe even having a bowel movement. Like a simple tip, we say, like, grab a pillow and you hold that pillow. Obviously, when you're sneezing, that's going to be very hard. So we try to think of like different aspects, that there's little tips and advice we can get to you, because we're pretty much, we like to say and classify in physical therapy, like we're pain experts. And so we teach you how to experience the pain and how to even cope and manage the pain when you're trying to recover. So that can look like, we also have like these little guides. We teach you how to use this before surgery so that you can do it after surgery. You don't go on the scar. So this is called
show us what this is. I don't know how to work this.
This is the fascial cup. And so you'll see on my hand, when I squeeze it, it sticks to my hand, and then I kind of just like glide it up and down my hand all the way here. You'll have like coconut oil or some sort of oil on you so you can glide better. But we teach you how to use this on your fascial tissue over your abdominals before surgery. So you're just using that before surgery to kind of prep that tissue. And then after surgery, we hold off on this and you use your hand. And so same techniques, we're just moving around, we're going around the scar, not on the scar. And then we'll teach you techniques how to start doing scar tissue mobilization. But we don't start that until like 6 to 8 weeks. We technically start it a little bit earlier because we watch scar tissue healing and see when it's appropriate to actually start doing those techniques.
That's a great idea. And you can get this off Amazon?
Yeah, you can get off of Amazon.
Okay, perfect.
Yeah.
So one more reason to see a physical therapist before surgery is to get the fascial cup.
Yeah.
Any other tips and tricks you have for our patients after surgery? Is all physical therapy the same?
No.
Right?
No.
Pelvic floor physical therapy is a very special subset.
Mhm.
And I always tell my patients they can't use Google to find a physical therapist because a lot of those physical therapists may be focused at performing strengthening exercise for the
Yeah.
pelvic floor.
Yeah.
So can you tell us a little about how the physical therapy, your approach to pelvic pain may be different than a standard physical therapy session for prolapse?
Yeah, so we are specialists. So we have specialized training. We've not only done our years of schooling in physical therapy school, but then we do extra training. And when I say extra training, we're talking years. All of our hours are spent on specializing with the pelvic floor. So, like you were saying, we see a lot of pelvic pain and then pelvic pain with prolapse because what happens are they feel this bulge or the heaviness, and your natural reaction is to squeeze, tighten up everything so you can feel like you have control of your pelvic organs. And so what we do is we reteach that body on how to actually let that tension go, and then other exercises, whether it's mobility exercises, strengthening exercises, talking about the nervous system. Like Dr. Mallorie was saying, we go through that whole blueprint of nervous system, the structural system, hormonal, other systems, and then working with other physicians and providers too.
Perfect. That
Yeah.
sounds like a great plan.
We're taking that whole
Yeah, now let's talk
approach.
about how we can incorporate
Yeah.
surgery into
Yeah.
the pelvic
Yeah.
pain
You got it.
plan.
So when would be like a good time someone should get surgery? Like, is there a good time?
It depends on how and when the patient presents. If the patient goes to see physical therapy first because they've heard that physical therapy can help with pelvic pain, most of the time the physical therapist would have worked with the patient for a little bit, tried to see how much of the pain they can manage. And then when they realize that the patient still has residual pain, like you said, based on your assessment, that could be systemic or could be due to an organ dysfunction, then they may be referred to a pelvic surgeon like myself.
Mhm.
A lot of the times, unfortunately, patients' pain gets dismissed. So by the time I see my patients, they've seen 3 or 4 other doctors. They've mentioned their severe pelvic pain, and they've been told it's just a bad period. Let's just keep trying. If my patient comes to see me and they've already been through multiple years of pain, seen multiple doctors, try different modalities, then I tell them, let's not delay surgery any further. You've waited years and years of suffering and pain. Surgery is the only way to diagnose and treat endometriosis if it's there.
Mhm.
But I also remind them that surgery is not going to be a magical treatment. It is a complete plan that we have to put in place involving different specialties, so a multidisciplinary approach. And the pain can be coming from endometriosis. It could have triggered the muscle and nerve dysfunction.
Mhm.
But if we don't address the muscle dysfunction independently or the nerve dysfunction independently, we're not going to get complete resolution of the pain. So I try and offer them surgery quickly, 2 or 3 weeks after our initial visit,
Mhm.
just because I know how long they've been waiting. But I also remind my patients surgery is not an emergency. It's not a life-threatening situation. We're here to improve your quality of life. So you decide when would be a good time for your surgery. Sometimes people have commitments, school commitments, work commitments. I just don't like to see my patients suffering through more periods
Yeah.
because surgery is the only way to give us answers as to whether or not they have endometriosis. But then after surgery, they continue to work with the physical therapy team. They see a pain management specialist if necessary, a bladder specialist if they're having bladder issues. Knowing that the endo has been resected and is gone, we then work on the additional pain generators.
Love it.
Yeah. And so when you do the surgery, what are you looking for?
So that's a good question. So endometriosis is a disease that is commonly caught or a common cause of pelvic pain. So endometriosis in a lot of women can cause chronic pelvic pain. It presents itself very differently. Some women will have pain just with their periods. Some women will have pain with intercourse. Some women will have pain throughout the month. We can suspect it based on their symptoms, but the only way we can diagnose and confirm its presence is through laparoscopy. So surgery involves an incision through the belly button. We go around with a camera and we look at the pelvic organs. We look at the diaphragm. We look at the bowel. We look at the uterus, tubes, ovaries, bowel behind, and bladder in front. And what we're looking for is classical lesions that look like endometriosis. So usually they're blue-black spots around the pelvis. Sometimes they're clear vesicular lesions. Other times they're red. You really have to have a trained eye to detect those lesions because they're oftentimes missed. And when we find those spots, even just visually looking, I cannot say that there is endometriosis. I have to cut it out, send it to the pathologist who will then check under the microscope and confirm the presence of endometrial glands and stroma. So diagnosis is not clinical. Usually diagnosis is through surgery with pathology. So the pathologist can confirm the presence of endometriosis.
Okay. And then I have a quick question
Yeah.
about that. When you also do labs to confirm some of these findings, or at least give you more insight, what labs are you looking at?
Actually, there are no labs to diagnose endometriosis. There are definitely a lot of studies that look promising, where we're trying to identify if there are markers through blood or through endometrial biopsy that can detect the presence of endometriosis. There is one that we sometimes will perform with a fertility treatment, but it's not an accurate test. The false positive rate is high, the false negative rate is high. So ultimately, the only way is surgery. We can perform an ultrasound before surgery. I always recommend that because it allows us as surgeons to look at the anatomy between the ovaries, the uterus, the bowel. I can see if there are adhesions. I can see if there are bowel lesions or bladder lesions, but I cannot confirm the presence or the absence of endometriosis without surgery.
Okay. And then if someone is trying to get pregnant, right, how does this impact or improve fertility chances?
That's a great question. So endometriosis can cause issues with pregnancy. 70% of women with endometriosis will get pregnant naturally, but 30% of women will have infertility. And many times it gets missed or placed in the category of unexplained infertility, because the tubes would look fine, the eggs would look fine, the sperm would look fine. And the REIs or fertility doctors are at a loss as to why this couple cannot conceive. But if you dig a little further and ask patients about their menstrual history, you'll probably pick up on the fact that they've had painful periods for years. They may have pain with intercourse, they may have pain with bowel movements. Those are all signs and indicators that there may be endometriosis creating an inflammatory situation in the pelvis that would make fertility more challenging. And interestingly, once we go through surgery to diagnose and treat and remove all the endometriosis, a lot of those patients have been able to get pregnant naturally, proving that endometriosis was the cause of their infertility. And it's mostly related to inflammation around the organs, but also sometimes the inflammation can lead to adhesions and scar tissue. And the scar tissue can block the tube so that the egg and sperm can't meet. The scar tissue can also change the direction of the uterus, of the ovaries, of the tubes. And also sometimes if the endometriosis is on the ovary itself, it can damage the eggs that are trying to grow. And so pregnancy chances with endometriosis are diminished, and we shouldn't just try and patch it up with IVF. We need to go in, clear the disease, and then help our women get pregnant, because this way they have a higher chance of success and they have a higher chance of getting pregnant naturally without needing fertility treatment.
Yeah.
Any other questions from our physical therapist about endometriosis surgery? It's a great team that we have here, because I like to communicate directly with my physical therapist treating my patients, so I can know what's lacking, what I need to work on, and I can communicate back to the physical therapy team about what I found during surgery, so they can further identify the areas that need to be worked on.
Yeah, I think that's a great point too. Like after surgery, like you can see the incision scars, but we know that you're going a lot deeper too. So when we know where you're at in surgery, we can also be in other areas of the body too.
Correct. And where
So-
those deep lesions are, right?
Exactly.
So sometimes patients say, my pain is on the left, and we go in and very clearly we see a deep endometriotic implant on the left uterosacral ligament invading into their pelvic floor. And so we know that this area needs more attention, because we were in there cutting around, moving things around. That creates more tightness and trauma to the area that the physical therapy group can then help relax and get rid of.
Yeah, and then to go off of that, I'm going to do more like endo and fertility. So for endometriosis, if we're known, like, okay, there was infiltrating endometriosis in the bowels, then we would be like, okay, so we're going to focus a lot on bowel mobility. We do what's called visceral work. So we'll get our hands, and think of body work, onto your organs through the abdominal wall, and mobilize your tissue and just see like, okay, where do we feel restrictions, and kind of take you through that to see if we can open up more space after that surgery to continue to remain that opening. And then for fertility, the same aspect. Let's say that there was endometriosis over the fallopian tube or ovarian region, uterine region, wherever it was impacted, even if it's, sorry for endometriosis, but for fertility, if it's in the ovarian, fallopian tube or uterine region, we can go in and do mobilization in that area too. So it looks the same thing, body work. We put our hands on there and we kind of mobilize that uterus and see where do we find restrictions. So yeah, she's going to show you right here.
How it can move.
Yeah, because
That's
it
perfect.
moves in
Yeah.
all ways.
I think we all agree that collaboration is key here.
Mhm.
And when you are choosing your physical therapy group or your surgeons, just make sure that they can communicate and collaborate with each other, all with the aim of providing you with the best pain relief when possible.
Yeah.